Shani Sivaratnam I'm an ophthalmologist from UPM, and I have the great honor to introduce to you our guest speaker, Datuk Dr. Linda Teo from Tun Husainon National Eye Hospital. She's a consultant ophthalmologist and a glaucoma specialist. Datuk Dr. Linda Teo graduated with an MBBS degree from University Malaya. She then served as a captain in the army with the Ministry of Defense, and she did her master's in UKM. This was followed by her fellowship training in glaucoma subspecialty with the New York Eye and Ear Infirmary in New York, USA. She has worked with Tun Husainon Eye Hospital for more than 20 years. Along with her, we have Mr. Robert Kong, who is a 50-year-old patient of Dr. Linda, and he will be talking about his experience suffering from glaucoma and the treatment that he has received. Okay, Dr. Linda, maybe you would like to start your presentation now?
Good afternoon, everybody. Thank you, Madam Chairman, for the kind introduction. And I would like to thank Dual Pharma for inviting me to participate in this conference today. The topic today is don't be blindsided by glaucoma. So shall I start now,
yes.
Madam Chairman?
Yes, please. Yes, please, Dr. Linda.
I'm going to share my slides now. Can you see the slides?
Yes.
Glaucoma is very important in our everyday life because glaucoma is the #1 cause of preventable irreversible blindness. As of this moment in time, in the year 2020, 76 million people in the whole world have been affected by glaucoma in a way that either their distance vision is affected or the near vision is affected. It has been projected that by the year 2040, at least 110 million people would be estimated to have glaucoma in their eyes. So what then is glaucoma? Glaucoma is a group of neurodegenerative disease whereby 2 out of the following criteria must be present. #1 is there must be optic nerve head damage. That means there must be structural damage, which is in addition to the visual field loss, whereby the visual field of a patient is affected. If you have just only increased pressure, you are in the range of a ocular hypertension because there's no optic nerve damage and there's no structural and no functional damage. In cases whereby you have normal tension glaucoma, you may have normal pressures, but then the visual field is affected. So in the normal glaucoma, you have both visual field and structural damage and functional damage as well. Then we call it as glaucoma. So who are the people who are at risk for getting glaucoma? Basically, it is a condition of more elderly people. If after the age of 50 or 60, there's a higher risk of getting glaucoma. If there's a strong family history, it makes a person having 10 times the risk of getting glaucoma. And those people who have diabetes and hypertension, whereby the diabetes and hypertension are not properly controlled, it puts them in the category of having a higher risk of glaucoma because diabetes and hypertension causes ischemia to the retina and which induces new vessel formation which can subsequently bleed and lead to formation of glaucoma. People who have born with higher pressures than normal, they are the ones who also have a higher risk of getting glaucoma. People who are very short-sighted or who are very long-sighted, they are also at the higher risk of glaucoma. Glaucoma is also present in different genetic groups. mainly in the African Americans. They are found to have a higher risk of getting glaucoma. And in the Asian group, it's mainly the people of Asian descent, such as the Chinese, the Japanese, and the Koreans. They are at a higher risk of getting angle closure glaucoma. Even the Eskimos are also at a higher risk of getting angle closure glaucoma. The other groups have mainly have open angle glaucoma. The Scandinavians, they are at the higher risk of getting pseudo-exfoliative glaucoma. So actually, there are more than 40 different types of glaucoma, and one of the common ones is also due to long-term use of steroid. A lot of patients who are taking topical steroids for conjunctivitis, allergic conjunctivitis, if they are a steroid responder, they may end up with having glaucoma if they don't have frequent monitoring of their intraocular pressures. So we look at the anatomy of the eye, which is the part of the eye that is important when we want to talk about glaucoma. Looking at the picture from the front to the back, you have the cornea, which is the transparent area in the cornea, which allows light to enter from outside, and it gets focused by the lens and focused onto the retina. The optic cup or the optic disc is the part whereby we have to concentrate on when we assess patients for glaucoma, because when the eye will produce aqueous, which helps maintain the shape of the eye, as well as provide nutrients to the parts of the eye like the cornea, which is devoid of blood vessels. So the area which is involved here is the anterior chamber angle, whereby the aqueous is formed, and from there the aqueous is removed from the angle right into the subconjunctival space. So when there is increased pressure because of abnormality of the anterior chamber angle, either because of resistance or because of sudden closure, there is a backward pressure built up in the eye itself, and this back pressure will produce pressure onto the optic disc, which is right at the back, which is the nerve that send messages from the eye to the brain. So this part is damaged by increased pressure, and constant increased pressure will cause the cupping of the optic nerve to increase in size, and that's how we monitor the stage of the glaucoma by looking at the optic disc cup. So what happens to the eye in glaucoma? Like I mentioned earlier, looking at the very first picture on your left-hand side, in a normal drainage, the angle is open, and that allows a easy passage of the aqueous from inside the eye to outside the eye. But when there's a blockage of the drainage channel, the intraocular pressure raises, and that causes pressure onto the optic disc. As you can see in the picture on your bottom right side, there's the optic disc, and that's how we monitor the stage of glaucoma. So with progression of glaucoma from this chart, you can see the number one, where you have normal eye pressure, the optic nerve, where you have the rectangle, and at the bottom is the visual field. So when the person is normal, there's a normal field of view, you have 100% field of view, so you can see well periphery as well as in the center, and the normal optic cup is about 0.3 to 0.4 in size. As the intraocular pressure builds up, more and more of the nerve fibers are damaged, and then that leads to increase in size of the optic cup, and the nerve fibers inside the optic cup are spread more peripherally. That's why the cupping increases, and as this happens, the peripheral vision is affected. Like in the third picture, you can see that there's an aqueous scotoma, whereby the black area is blocking part of the view. If nothing is done to halt this damage, the damage progresses until the optic disc becomes very cupped, and if you look at it, you can see from between size number 1 to number 3, the size of the cup becomes very large, and that indicates a very advanced glaucoma. And looking at the visual field right at the bottom right hand side, you can see that the visual field is all dark now, with just a small island of field left in the inferior temporal area. So this is how glaucoma progresses when unhalted, and it subsequently leads to blindness. So now, glaucoma is interesting because there are many ways you can classify glaucoma. A very common way is to classify them according to the age of the patient. This way helps us to understand at what age the patient has glaucoma. So if we develop from glaucoma right at birth to about 10 years old, we call it congenital glaucoma. This often happens when during pregnancy, the mother antenatally got rubella. That's the most common cause of congenital glaucoma. Sometimes it's hereditary, so the patient is born with buthemos, and that signifies it's a congenital glaucoma. As the other stage is when it's after the age of 10 years, but up to about 35 years, we classify it as juvenile glaucoma, and anything after 35 years, we classify it as adult glaucoma. Unless, of course, it's a child who got secondary glaucoma from the use of steroid or from trauma itself. Then we wouldn't call it just juvenile glaucoma. We'll call it a secondary glaucoma, secondary to use of steroids. We can classify glaucoma according to the cause. Primary means there's no known cause. A lot of times the patient asks, what's the cause? Actually, there's no known cause. Why there's a resistance to the flow of the aqueous? Nobody knows. And so far, we haven't been able to identify the cause. Secondary means it occurs after something like trauma, when you have, a lot of people play badminton and they've got shuttlecock injury into the eyes. Yes, it's a common injury and you can get angle recession glaucoma from this trauma. And you can take steroids, or in following things like diabetes and hypertension, and of course any other ocular diseases like uveitis as well. The most common way to classify glaucoma is according to the site of obstruction of the drainage system. This is an easy way to classify, because then it helps us to understand whether the angles are open in this glaucoma or the angles are closed, because the initial management for open angle glaucoma and angle closure are totally different. So here shows you in diagrammatic form on your left-hand side that is a primary open angle glaucoma. The arrows signify the aqueous being produced from inside the eye behind the iris, flows out through the pupil into that little small area which is called the trabecular meshwork. So in this way, in this picture, you can see the flow is okay, but the resistance to the flow is there, and it causes a resistance to the intraocular pressure, causing subsequent increase in intraocular pressure. But there's no known cause why it happens, so you call it a primary open angle glaucoma because the angles are open. The picture on the left-hand side shows that the iris is bunched against the side of the cornea, so that means the angles are closed. And now you look at the arrow, the aqueous cannot flow through the angles because it's blocked, and so it causes a backward pressure, and in this case it causes the building up of a pressure which is significant enough to cause headaches, to cause the patient to have eye pain, to cause the patient to have sudden decrease in vision and redness of the eye. This is usually what happens in primary angle closure glaucoma, which is an acute emergency because the patient is in pain and often presents with nausea, vomiting and headache to their general practitioner. So actually, when we talk about symptoms, primary open angle glaucoma, there is no symptoms at all. So that is why you call glaucoma as the silent thief of sight, because it slowly damages the vision without realizing it. And a lot of times patient presents for a general checkup, or because the family members have got glaucoma, they come for a regular routine checkup and they are found to have glaucoma. However, on the other hand, the people who have a primary angle closure glaucoma, because the angle suddenly closes and the patient gets pain in the eyes, they present with primary angle closure glaucoma and you detect it because of the pain. However, another group of patients which is called the subacute or chronic glaucoma, you can have a chronic glaucoma whereby slowly the angles closes. Patients may have on and off blurring and pain in the eyes, because if it lasted for a few seconds, the damage continues to happen, and one fine day suddenly the angles close and the patient presents with acute on chronic angle closure glaucoma. And in this case, there will be also detrimental changes to the optic nerve. So talking about glaucoma now, what we are interested in is how do we diagnose glaucoma? As you can see, the three pictures here, these are part of the essential tests that we need to do. First, to establish a diagnosis of glaucoma, and subsequently for us to monitor the progression of the glaucoma. So how do we do that? We need to examine the patient at the slit lamp. Like you can see, the patient sits at the slit lamp. We check the intraocular pressure, we check the condition of the optic nerve. So by doing the intraocular pressure, what we do is we use this, what you call the Goldman applanation tonometer. First, we put a local anesthetic with a fluorescein dye into the eye, and using this tonometer, we place it touching on the cornea. It won't be painful because the cornea has been anesthetized, and we read up a pressure from a gauge at the top of the tonometer. This is a very accurate way of checking the intraocular pressure. And then the second, after that, we look at the angles of the eye. When the patient is first diagnosed to have glaucoma, we have to know whether is it an open angle or an angle closure. So we do what you call a gonioscopy. How we do a gonioscopy is, again, we anesthetize the eye, and then we subsequently put a small mirror, which we call a gonio prism, onto the eye, and from that prism, we assess the drainage system, whether it's open and to what degree is it open, or is it closed, or is it narrow, or is it occludable. So we can get quite a bit of information from doing the checkup for the angles, and that helps us to plan how to treat the patient. And subsequently, we look at this is the optic disc that I was mentioning just now, which is the one and the thin rim of the retinal nerve fiber around it, it gives us an idea how big is the cup disc ratio. I mentioned earlier that normal is between 0.3 to 0.4. What is important is that some people can be born with normal cups, so we cannot be sure they have glaucoma or not unless we assess them for glaucoma. And after that, we monitor the stage of the glaucoma by monitoring the size of the cup disc ratio. And some people can be just born with large nerves. It's just like, I always tell the patients, it's just like you buy a donut. If you buy a big donut with a small hole in the center. So subsequently, when the patient is born with large nerve, you will expect the cup to be big. So we have to really to confirm whether is it a normal cup or is it a not normal cup. And that we do by doing some investigations. And the fourth test that we do is now to check for the visual field. So the first step is checking the pressure. The second step is checking the structural changes in the eye, looking at the angles of the eye. One that is important for us to diagnose glaucoma and to monitor glaucoma is the visual field. The visual field is actually a test that helps us to assess how much of the visual field is functioning and how much has it been lost. So this is the only option. This is only a functional test the optic nerve, and it is an important stage of testing. And here you can see you can do it by the automated perimetry. Perimetry is another word for visual field, and the patient is tested one eye at a time. And of course, the patient to get accurate results, the patient has to be attentive and to follow instructions. And we do the test one eye at a time. And this is important for us to establish a diagnosis of glaucoma and to help us to monitor the progression of the glaucoma, because just monitoring the intraocular pressure itself doesn't tell us how much progression the glaucoma has happened. So it is important for newly diagnosed glaucoma patients to have their visual field done at least 2 to 3 times a year. For those who are already well controlled and compliant with the medication, we can just monitor them quite safely once a year if they are very compliant patients. Of course, if the patients are not to be trusted and who are not compliant with the medication, you may have to repeat the visual field more often. Unfortunately, this is not an easy test to do, and a lot of times the patient will try to give excuses not to do this test if possible. So we have to explain to the patient why it is necessary to do this functional test for monitoring the glaucoma. This shows that the other test that we can do is OCT, which stands for optical coherent tomography. This usually I tell the patient is that you're doing a CT scan of your brain. This is a CT scan of like doing your eyes, your optic nerve, and we don't use the radiation. This is just using light, and you're using the light to look at the optic nerve at different cuts of the eye. It's like looking at the cross section, and you look at the picture on the right hand side, you can see the 4 small little rounded areas at the bottom. It just shows us the size of the optic cup, how deep it is, how wide it is, and how much is the thickness of the nerve fiber in each different quadrant. The very first chart on the top hand side gives us a comparison of the average size of the right eye and the left eye. The picture on the left is for the right eye, the picture on the right is for the left eye. So this will tell us how is the distribution of the retinal nerve fiber layer, which flows into the optic nerve and gets carried to the brain. So this is an important assessment for the structural changes in the optic nerve. This is a final summary for what we do for glaucoma patients. First is you have the OCT, which is on the top left-hand corner, followed by the HRT, which is another machine that you can use to monitor the retinal nerve fiber layer. Sometimes you can even gauge the glaucoma by looking at the picture itself. So you see the disc photo, and below the disc photo is a visual field, which is a Humphrey CITA 24-2. There are many programs to assess the functional status of the glaucoma, and this shows a very typical visual field loss in a glaucoma patient, which is a superior arcuate. You can see the upper half of the visual field is affected, and it goes into join the blind spot. And again, the GDX is another assessment of the retinal nerve fiber. Here is to show you that different centers may use different machines and different technology to measure the retinal nerve fiber layer. So what actually are the goals of treatment? So the goals of treatment is actually we want to preserve the visual field such that the patient is able to be independent, and such that by using the whatever treatment that we are giving, there's minimal or no side effects for at least the lifetime of the patient, without any disruption of the normal activities, and of course at the cost that is affordable to the patient. So how do we do that? The goal of the treatment is, as I mentioned, to maintain the visual field function of the patient, we know, glaucoma eye drops are all very expensive. So sometimes the patient may spend even up to $500-600 just to use glaucoma medication. Test and the OCT. So technically, glaucoma is an expensive disease. And of course, when we use treatment for the patient, we must make sure that it's not inconvenient, and we must make sure that the side effects are tolerable. As we know, all medications have some form of side effects. So sometimes the patients may have dry eyes, may have red eyes, may have pigmentation with the eyes, which make them very reluctant to continue the medication, affect the compliance, and of course, once the compliance is affected, the control of the glaucoma is affected, and the glaucoma may progress. And the lifespan of the patient is important. If it's a young patient, we would be more aggressive with the treatment. If it's a very elderly patient, we may not be so aggressive in the treatment. And it also depends on what they do in the life. And so the quality of life is important for the patient. All in all, what we want is the patient to be independent, that the patient can wear their own dress, the patient can eat themselves, they don't need help for all this daily necessity. So this quality of life would be reduced if both the eyes have shown advanced visual function loss. So our aim is to maintain the visual field for as long as possible for the patient to be independent. So for treatment of glaucoma, we can do in many ways, and the idea of the treatment of glaucoma is to lower the eye pressure or the intraocular or ocular pressure. And currently there are many ways of doing this. But what is important is sometimes a patient come and tell you, oh, my friend is using this, my friend is using that, my friend has this done, my friend has that done. But what is important is we must realize that each patient is individual. Even though the general principles of treatment are the same, we still have to individualize the treatment for that patient. So whenever we see a patient at the very first time, we assess what type of glaucoma they have, what stage of glaucoma, and then we set a target pressure for the patient. So the target pressure is not the same all the years through. The target pressure can be changed at any time for us to make sure that the patient do not progress, that the visual field don't get worse, and we're able to maintain the visual function for as long as possible with the present treatment. So what types of procedures we can do are mainly, the first stage is start off with medication. So the pharmaceuticals are there, when we start usually with topical eye drops. Then of course we can consider certain lasers like selective laser trabeculoplasty for people who want to go for pregnancy, because not all medications are safe for pregnancy. So we may consider SLT for such young ladies who intend to get pregnant. Sometimes we have to consider internal surgery with a form of treatment where you go through inside the eyes and do surgery to the anterior chamber angle, or we do a filtration surgery, which is one of the common surgeries we do for glaucoma. At any stage where filtration surgery can be done to help us to control the pressure. And of course, the last one is a drainage system where we put in a glaucoma drainage device, which we usually do for very uncontrollable or retractable glaucoma, whereby the glaucoma is difficult to control.
Okay, thank you so much, Dr. Linda Teo. So now we are going to meet Mr. Robert, who is a patient of Dr. Linda, and he's going to tell us about his experience with glaucoma. So good afternoon, Mr. Robert.
Hey, good afternoon.
Can you tell us about how long you have been suffering with glaucoma?
Okay, I was first diagnosed with glaucoma in my mid-teens, maybe 14 or 15 years old. Yeah, that was the first time I was diagnosed with glaucoma.
And what kind of symptoms did you have?
I had frontal headaches in the front part of the head, and I felt there was like something pressing the eyeball. Yeah.
Does any of your family members also suffer from glaucoma?
Yes, my dad has glaucoma, but he was diagnosed with glaucoma quite late in life. Earlier part in his life, he never had glaucoma, and his sister also had glaucoma, but they had glaucoma very late in life. I was diagnosed with glaucoma before my dad.
I see. And what about your siblings? Did you have any other brothers or sisters who also had glaucoma?
I have 3 siblings, and none of them has glaucoma.
None of them.
None of them.
I see. Was there any pain in your eye? So you basically just presented with some frontal headache, is it?
Frontal headache, and I felt there was something pressing the eyeball, like the eyeball is under pressure.
Did you have any blurring of vision or loss of visual field?
At that time, no. Of course, later on as it progressed, today I have some loss of visual field. I think I've lost about maybe 40+% in both eyes.
I see. So both your eyes are affected?
Yeah, both my eyes are affected.
Is any one of the eyes even worse than the other? Or is it equal?
It's around equal, but my left eye, the visual field and is quite stable. It doesn't change much over the years. Unfortunately, my right eye, I have been losing slowly. My right eye, I had greater visual field, but now it's almost the same as my left eye. So each eye, I've lost 40+% on the top portion of the field.
Okay, Mr. Robert, can you elaborate a little bit and tell us about what procedures and what treatment you have received for each eye? Perhaps start with your right eye since it was the better eye.
Okay, when I was young, after I was diagnosed, I was given some eye drops. It has been so long ago, I can't remember what eye drops. So I've been on eye drops for some time. And after that, in my late 20s, the eye drops became ineffective. I was working overseas then I was given oral medication. But I couldn't go on without medication because it made me very tired. I couldn't walk 2 flights of steps without, panting. So at the age of 30, I had surgery on both my eyes. Both eyes.
Mr. Robert, when you were put on medication, were you compliant to treatment?
Yeah. I've always been compliant.
So you were putting your eye drops diligently every day?
Yeah.
And how many bottles of eye drops were you asked to instill in each eye?
When I was young, I believe it was 1, but I think probably changed different eye drops throughout the years. At this stage in my life, as of now, I'm using 2 different types of eye drops.
It's very challenging for young patients to have a disorder that requires them to be putting eye drops several times a day and daily. I mean, I'm sure everyone over here who has taken antibiotics, I'm sure you have some experience of if it's 3 times a day or 4 times a day. I doubt everyone is going to be fully compliant to putting taking even their oral antibiotics, which is required sometimes just for 5 days or 7 days. So this is one of the challenges that glaucoma patients suffer from, in which they have to be on eye drops 2 times or 3 times a day, and often several types of eye drops. Did you ever suffer from any side effects when you were using these eye drops?
Only in recent times, side effects in terms of the some blackness, darkening, of the eye, lower part of the eye. But in terms of my daily functional life, I don't suffer any side effects.
You don't have any problem of dryness, tearing, discomfort?
No, not not really. Dryness maybe slightly, but it's not very pronounced.
I see. That's great. That's fantastic. So other than putting eye drops, Mr. Robert, what other treatment did you have to undergo?
Okay, like I said, when I was 30 years old, I had surgery done on both my eyes. Then the pressure was stable and relatively low for quite many years. I believe when I was around 40 and pressure started to creep up, and I had to go on drops again.
So you were relatively free from any medications after the surgery for about 10 years.
Yeah, that's correct.
That's wonderful. That's fantastic. And that's, I think, what every surgeon hopes for. Okay, I think Dr. Linda would like to continue with her presentation. Thank you, Mr. Robert.
Thank you. Thank you.
Okay, so now we will talk about the medical treatment of glaucoma, which is the main topic for today. So I won't talk much about surgery or other subsequent forms of treatment. So how do we go about the treatment? So what we usually do is we try to start off with monotherapy. That means to say we try to use one eye drop as far as possible to control, because this will improve the compliance and the adherence of patients. So the first choice of monotherapy can be prostaglandins, beta blockers, carbonic anhydrase inhibitors, alpha-2 agonists, or others. But our mainstay is nowadays we start to use the prostaglandins, because prostaglandins have the least side effects possible. I'll elaborate much later. So looking at the chart, just follow with me. Well, when we start off with one choice of monotherapy, if the drops is well tolerated and the IOP is effective, remember just now I mentioned we have to reach a target IOP. So if the IOP or intraocular pressure is well tolerated and reached, then you go right to the bottom, the target is reached, then periodically we will do the visual field, the optic disc, the intraocular pressure check regularly, and hopefully that helps to maintain the quality of life for the patient. Okay, what happens if we use the eye drop, patient can tolerate, but the target pressure is not reached? Then we may switch to another medication. Rather than add, we switch. Or worst to worst, we add a second drug. And again, if the target pressure is not reached, it goes on, either we change again, substitute the drug, or to add the medication. And at some point, if let's say the patient reaches up to the 4 types of maximum already, and there are no more medication to add, or the patient starts having intolerance to the medication, non-compliance, then we have to consider surgery. Surgery, actually, we do is when the patient is not compliant, when there's no improvement, patient has difficulty following, the glaucoma is progressing. So these are the indications for surgery. Okay, going back to the top, right from the start, we already start on the one medication is not tolerated. The simple thing is we switch the medication. Usually we keep on switching the medication until we find one that patients can tolerate. But if one medication is not enough, we will add one becomes 2, 2 becomes 3, 3 becomes 4, and that becomes the maximum. We try not to put on systemic medication, because you see, like Mr. Robert mentioned to you, systemic medications have side effects. Systemic medication is the mainstay is Dimox, which is acetazolamide, and if you have to take about 4 times a day, and usually it causes a lot of lethargy. Patients become very tired. Sometimes if they use for long term, they even develop depression. The other side effect is that the patient may eventually develop kidney stones, and another thing is that the patient may find that if those patients who have allergic to sulfur drugs, we try to avoid them because they may develop sulfur allergy to Dimox as well. Okay, so you can see from this, I'm just showing you that glaucoma medications have been used since the year 1875. Pilocarpine, as you know, is a miotic, which helps to improve the control of the pressure by constrict, and that subsequently increase the outflow of the eye and increase the pressure control. But pilocarpine it was used a long time ago, but not popular now because it makes the patient have brow ache, discomfort. Patient finds that the vision is very poor because the pupils are constricted and less light goes into the eye, and it's not so tolerant for patients or younger patients. The elderly patients are quite alright. However, pilocarpine is still the mainstay of medication for acute angle closure glaucoma. as you can see, we have the chart until 2014, whereby you got a lot of new drugs, newer and newer drugs coming to the market, but it's not like every year. It takes many years for research, and subsequently they find the drug is safe to use, and then it put it into the market. So you can see from the list on your left-hand side, the ones that is very effective is mainly the prostaglandins, which can drop the pressure by about 25 to 35%. Subsequently, you can have beta blocker, which is we can drop the pressure by 20 to 25%. One thing interesting is that long before the prostaglandins came in the 1996, we'll start with latanoprost. Before the advent of the prostaglandins, beta blockers was the mainstay. Until recently, beta blockers were still the mainstay in a government hospital because prostaglandins are expensive, and beta blockers can be used at a very small fraction of the price of prostaglandin. So we have the 5 main drugs group that we can use for glaucoma patients, mainly prostaglandins, which are like latanoprost or Zalatan. Now you have a lot of generic forms of Zalatan, which was originally produced by Pfizer. Then you have bimatoprost or Lumigan from Elegant, and you have Travaprost or Travatan from Alcon. And then you have Taflutan, which is a Tafluplos from Santen. So there are many groups and many market drugs being marketed at the moment. Then you have beta blockers. We are mainly the Timolol, which is non-beta selective. So we do not want to use Timolol or beta blockers, which are non-selective for patients who have heart block, for patients who have heart problem, and for patients who have asthma, because it will aggravate their factors. They are the problems. For those patients who need the beta blockers but have all these heart conditions and lung conditions, then we use betazolol, which is a beta selective beta blocker, which will not affect the lungs and will not affect the heart. Then you have the alpha agonist, which is the epaclonidine and the brimonidine. Epaclonidine is not so popular because we use it mostly, we instill into the eye just before we do laser iridotomy. Brimonidine is alphagon, which is commonly being used. I'll go into further about this medication later. Then you have the topical carbonic anhydrase inhibitors, which are the brinzolamide, dorzolamide, which are in the same group as the acetazolamide. Then myotic, as I mentioned. Now what is popular nowadays is a fixed combination. That means to say in one bottle of the medication, we have 2 drugs inside. So it helps to cut down the number of times that the patients are using the eye drops, and it's also fixed combinations are also cheaper than 2 bottles, the cost of 2 bottles of different medication. So you have beta blockers with prostaglandins, such as Zalacom, Duatraf, and Genfort, and Taflocom. And then you have the beta blockers and alpha carbonic anhydrase inhibitors like Azaga, Kosop, and then you have alpha agonists and carbonic anhydrase inhibitors like this is Simbrinza. So here I'll just roughly tell you what are the drugs that we have. The mechanism of action. The alpha agonists are like brimonidine or alphagon, and these work by reducing the aqueous inflow. And then we have the beta blockers, which is the non-selective, and the beta selective, which is decreasing the production of the aqueous, as well as increased outflow of the aqueous. Then you have the carbonic anhydrase inhibitors, the systemic one, which is acetazolamide, which is a Dimox. We hardly use metazolamide or diclofenac. Probably in the US you have metazolamide, but over this part of the world we have only acetazolamide, which is Dimox. And then of course the topical one is dorzolamide, Trusop, or brinzolamide, which is Azop. And the other one is you increase the aqueous outflow. You have the alpha agonist. Again, you have the brimonidine, the cholinergics, which is the pilocarpine. We don't use carbachol here. We use it mainly for operation users. The prostaglandins, which I mentioned earlier, and the lipid receptor agonist, which you use once a day. It helps to improve the outflow of the aqueous, as well as to work on the increase the uveoscleral outflow. So this prostaglandins is popular because it works on the uveoscleral outflow, which is non-conventional way of outflow of the aqueous from the eye. So the first choice of medication is actually usually depends very much on the doctor itself and depends on the patient, but majority of the time the general standard is we try to use a first line that is simple to use, easy to tolerate, least side effects possible, and if possible convenient for the patient to carry around. So the first line is the topical prostaglandin, and the original, which is the Zalatan or latanoprost, and you have the analogs of the prostaglandin as well. As I mentioned earlier, in olden days and in the government hospitals where the prostaglandins are not available, patients are started as a first line is beta blocker. So when the pressure is not well controlled, then we add a second line. So we add either the alpha agonist or alpha-GERD or the topical carbonic anhydrase, which is the Azop or the Trusop. And very infrequently, we use a pilocarpine. I mentioned the use of pilocarpine is mainly for plateau iris syndrome as well as for acute angle closure glaucoma, because you want to constrict the pupil and to help to open up the angles of the eye. So now we come to the prostaglandins. It's a very popular medication to start off with because it's only used once a day. So patient can either use it for once in the morning or once in the night, depending on whether the patient prefers morning or night. IOP, intraocular pressure lowering, is very superior to the other drugs. It causes less tachyphylaxis, less allergic reaction, and basically is very well tolerated systemically. It doesn't affect the heart, the lungs, or any kidneys or any other problems in the body. The side effects is mostly limited to the eye. And you can see it helps to increase outflow and decrease the pressure by at least 30 to 4%. So it does this by increasing the flow of the aqueous fluid through the ciliary body as well as through the uveoscleral or unconventional pathway. So this is what we mean by the side effects of prostaglandin. Why we call it PAP, or prostaglandin associated periorbitopathy, which is a real mouthful. So you can call it PAP. The most common, I start a patient of prostaglandin, I'll tell them straight away that your eyes will immediately look red. It is very important to tell the patient that the eyes hyperemia, because otherwise the patient will be thinking that, after using the drop they get conjunctivitis. So then you stop the medication. So first of all, you must tell them that when you use the eye drops, the eyes will be red. After a couple of weeks, the redness will go off, but it may never go off totally. Some patients will persistently have slightly red eyes. Some patients are rather good. Their eyes look red, don't look red after a while, after a few weeks. Then slowly they will notice that they have eye pigmentation of the lower lid. This is what Mr. Robert has mentioned as well. So you can get what you call panda eyes for some patients, because what happens is that they get this pigmentation around the eyes. This is not a very tolerant side effect for ladies especially, because they are very concerned of their cosmetic appearance. I have got patients also who are on prostaglandins and they come and tell me, doctor, my friends are always asking whether I'm a drug addict. I say, why? Because his eyes are always red after using the prostaglandins. So he may not be able to use prostaglandins, even though how effective it can be for certain patients if they are not tolerant to it. So as the time goes by, we're using the prostaglandins, what you can notice is that the eyelashes will grow longer. If you look at the picture on the lower left-hand side, you can see the eyelashes on the left eye much longer than the eyelashes on the right eye. This is a very happy side effect for ladies especially, because they are so happy with seeing the eyelashes grow longer. But it can go so long that it can just drop off easily, and you can even touch the glasses that they are wearing if the eyelashes grow very long. And the other one is that as time goes by, you notice deepening of the upper eyelid sulcus, which is called dews. This is because of the atrophy of the orbital fat as the time goes by, so the eye will look a little bit sunken. But the thing is that most of the time the patients themselves do not notice these side effects. These side effects are actually noted by the doctor or by their friends. And the eyelid pigmentation, which I mentioned earlier, is on the right lower lid picture. So these are what you call PAP, or prostaglandin associated periorbitopathy side effects, which is very common with prostaglandins. Some prostaglandins hardly have any these side effects, or the side effects are very low, and some prostaglandins cause more severe PAPs than others. So the effectiveness and the tolerability of the prostaglandins make them a very popular first choice for treating glaucoma. So most of the time we start off with prostaglandin. Then they have been shown to have the best lowering ability for the pressure, even against the beta blockers, and because they have very little side effects. And you can see that the effectiveness of the pressure control of the pressure starts about 2 to 4 hours after the first drop, which is administered, and it reaches its peak at about 8 to 12 hours. So usually if the patient uses prostaglandin, I'll tell them to start off by after about 8 o'clock in the night or 8:30 in the night, and don't put it later than 10 o'clock. Most of the time, their doctors will tell them, put it just before you go to sleep. I don't think that's a good idea, because when you tell them put it just before you go to sleep, they don't go to sleep at the same time every day, unless it's like a clockwork, that you put on the clock that you sleep at the same time every day. So if they sleep at different time every day, then the eye drops will be instilled at different time. So it is better for them to fix a time for them to put maybe 9 o'clock or 10 o'clock. So every day try to put it on the same time. So you try to cut down the fluctuation in the intraocular pressure, which is the important factor in causing progressive damage in the optic nerve. So when prostaglandins are not available or the side effects are not tolerable, we go ahead to use beta blockers. Beta blockers work by decreasing the aqueous production in the eye. It is a very effective way of reducing the intraocular pressure, but it is still less than prostaglandins. So the adverse effects that made beta blockers not the first choice is when the patient have got asthma, which has bronchoconstriction, or patient has heart block, which is bradyarrhythmias. And a lot of times patients who use the beta blockers say that they feel a bit blurry, they feel the eyes are dry, the vision is not so good because the corneas are clear, dry and hazy, so they may cause them to fall more often. And again, patients who've got heart failure, we also do not want to start them on beta blockers. The next is the alpha agonist, which is the iodopidine and alphagon. Iodopidine, the apraclonidine, we use it mainly for the pre-laser treatment, and alphagon, which we use it for up to 3 times a day use. Both of them by inhibiting aqueous production and increasing the uveal scleral outflow. However, what I want to mention about alphagon is that we try not to use it in the elderly and the young, especially the children, because the drug crosses the blood-brain barrier. And because of that, some patients will tell you they feel very drowsy after using alphagon. And in children, it can induce drowsiness. So we try to avoid alphagon in children if possible. The other thing about alphagon is that it is a very common cause of allergy in the eyes. A patient may be using alphagon or Simbrinza, which contains alphagon, for many, many years, and then suddenly one day they just come to you with very red eyes, the eyelids are very injected, the eyelids are crusty, and it's because they subsequently develop allergy to the alphagon. So that means to say that we have to stop the alphagon when this thing happens and then change to another medication. The other one that is popular for our daily use is the carbonic anhydrase inhibitor. As we mentioned earlier, systemic carbonic anhydrase inhibitors cannot be tolerated on a long-term basis. So now they have developed the topical use of carbonic anhydrase inhibitors. However, people who are allergic to sulfur, we do not want to take a systemic carbonic anhydrase inhibitor. We have also to be very careful with topical carbonic anhydrase inhibitor because it still contains sulfur. So it is a potent hypotensive drug, but patients don't like this carbonic anhydrase inhibitor because they will tell you that it causes a funny taste, or what we call dysgeusia. After putting the eye drop into the eye drop flows into the nasolacrimal duct and the patient can feel the taste in the mouth, and they tell you that it's a very funny metallic kind of taste. And also the medication is a bit sticky, so the patient will tell you that after using the eye drop, there's a lot of crusting on the lid and looks as if they never clean their eyes when they wake up. I think there's a lot of discharge. These are all due to the carbonic anhydrase inhibitors, which are left in the eyes, is dry up and causing this crusting effect. So I mentioned again here, those who are allergic to sulfonamides, we have to avoid these carbonic anhydrase inhibitors. And as I mentioned, you can get nausea, anorexia, abdominal cramps, paresthesia, diarrhea, and renal calculi are not uncommon in long-term use. So what do you know of maximum medical medication? So just now I mentioned when the patient reaches a medical therapy, that's MT, that means to say that we are already at a maximum. We are using all the tolerated medical eye drops that we have, and yet the pressure is not controlled, and then we have to switch to or add systemic Dimox, and then again the pressure is not controlled. When this thing happens, it means that we have no choice but to consider the next step, which is surgery. Of course, to make life easier for patients, we can use what you call a fixed dose combination, because it's found that the compliance of the patient gets less the moment you add more and more drops. And then we also tell the patient, whenever you use eye drops, don't put them one after another. Put the first drop, wait for at least 5 minutes, then put the second drop, so that there's no washout effect of the first drop by the second drop, which you put immediately after. So this will help to improve the outcome, the efficacy of the medication. And again, it fixed those combinations what I mentioned earlier, whereby you have a beta blocker together with one of the eye drops like a carbonic anhydrase inhibitor or the alpha agonist, or you have Simbrinza, which is a carbonic anhydrase inhibitor combined with alpha agonist. Patient must be really compliant, because if they are not compliant and they stop putting one of the eye drops, that means to say at one time they will be missing 2 eye drops, which is bad for the control of the eye pressure. So as I mentioned, when we reach maximum medical therapy, we may have to consider doing a laser trabeculoplasty, or we may have to consider the minimally invasive glaucoma surgery, which is currently the very popular surgery in the whole world. And also we can do cataract surgery together with the glaucoma surgery, and we can do a trabeculectomy, or we can do the glaucoma drainage device, or we call a tube shunt. And then those are the eye drops that we have been using for a long time. Now we have a few new kits of donating prostaglandins, which is a latanoprine, prostinbunol, and the ROCK inhibitors, or the Rho kinase inhibitors, which are like netasodium. Unfortunately, these 2 eye drops are not available in the country yet. They are still just past the what you call the trial stage. You can get a ROCK inhibitor, which is in the form of Glanatec or Ripasodil from Japan. I have a few patients who have brought this medication back from Japan, and they're using as a 5th medication for their use. And this shows you how the action of the latanoprostinbunol is on the eye. We won't spend too much time on it. And again, this tells you that they are almost as good as the prostaglandins, and they have been used for other problems in the body as well. The ROCK inhibitor sounds very interesting, because these are the one that relaxes the trabecular meshwork and so on, and improves the outcome and outflow, and decrease the intraocular pressure. So I think not too long from now, the ROCK inhibitors will probably be available soon. As I mentioned earlier, the Glanatec or Ripasodil, which is in this picture, the little pink box there, it is available in Japan as a Glanatec. Actually, patients can buy this out in the online as well. So where ROCK inhibitors are concerned, they seem to work very well for patients who have lower intraocular pressure at presentation. And studies have been done, like the ROCKET studies have compared their efficacy with prostaglandin. They have compared their efficacy with timolol as well. So the one that is now on this currently available, and which is called Ibelis, I think it is will be available soon in the country, is called OMD or omidinipeg isopropyl. It's a very mouthful to present. It works as well as a prostaglandin. It's a part of a prostaglandin, but it works so well in an EP2 receptor, but it doesn't have so much of the side effects of the PAPS, which I mentioned earlier. So eventually, when this comes in the market, it may become very popular as well, because it is also another prostaglandin without the side effects of the prostaglandin. Okay, so what is important here is when a patient is pregnant, don't forget, glaucoma doesn't affect only elderly people. It affects juvenile, it affects young people, it affects those people who are the age where they are still able to produce babies. So some of them are pregnant, want to get pregnant, and you do not want to let them continue the medication when they are pregnant, especially in the first trimester, and you don't want to continue to use them when they are breastfeeding. So we have to know about this category where FDA categorizes the effectiveness of the medication and the side effects they have as of ABCDX category, and we have to see which category our glaucoma medicine fits into. So here you can see that most of our medicine are in category B and C. That means to say that actually we do not have it we have not proven that they are safe during pregnancy. So most of the time we ask the patient to consult their gynecologist or obstetrician whether they are allowed to continue with the medication. If they really need to continue medication because the pressure is out of control or the glaucoma is very advanced stage, then we will tell them to puncture occlude. Puncture occluded means that you press onto the side of the eye to prevent the absorption of the medication. We press it for about 2-3 minutes after installation of the medication. So you can see from here that our medications are actually not proven to be safe during pregnancy, especially the first trimester, and the second trimester, if possible, try to avoid it as well, and as well during pregnancy, during breastfeeding. And again, here to tell you that medication, we have to evaluate the risk, and then we consider decreasing the medication, especially when the patient is pregnant. So what is the kind of approach they want to do for glaucoma management? So here are a bit of guidelines how to treat the patient as a whole. We don't treat the patient as one eye or two eyes. We must always remember the patient drives, the patient has to go to work. So we must make sure that whatever medicine that we use, it is efficacious to the eyes, it managed to intraocular pressure fluctuation, because we find that the response rate is important if the eye drops are efficacious. So because of the efficaciousness of the efficacy of the eye drop, we are able to stable the visual function. That means to say there's no further progression as far as possible or further damage to the visual field of the patient. As I mentioned earlier, I had patients who have very advanced visual field, but because they are very, very compliant patients, they managed to maintain the visual field even for 20, 30 years without further deterioration. Of course, with aging, there'll be some changes, but that is unavoidable because of aging changes. But because of changes due to poorly controlled glaucoma, this is become minimized by making sure that there's no fluctuation in the intraocular pressure. And then besides the stabilizing the visual field function, we must make sure that there's no systemic and the ocular side effects which is not tolerable to the patient. And finally, the ocular tolerability for the patient. So treatment should provide effective IOP reduction, but of course the effective IOP reduction must rely on the patient adherence. If the patient don't use the eye drop, I usually tell them, well, you can have the eye drop as long as it's in your pocket and it's not in your eyes, it won't work. So the eye drop must be into the eyes before you expect it to work. So patient adherence relies very much on the safety and tolerability of the treatment. And of course, the price of the medication itself. So sometimes the patient will choose to use a generic drug. It doesn't matter what kind of generic drug you use, and it doesn't matter which doctor you go to see. As long as you make sure your eyes get checked at regular intervals and make sure that you don't don't forget to use the medication. So the conclusion is that management of glaucoma in the daily practice is very important. It keeps on changing with time because new drugs come into the market, newer and newer ideas come on with investigations. And so the shift is resulting in earlier and more precise diagnosis. In fact, what we are saying here is probably now in the overseas, in the Western country, they have newer ways of diagnosing glaucoma. So when you select the appropriate therapeutic target, it's important to keep in mind the patient's characteristic, what the patients want to achieve or expect to achieve, and adapt the treatment according to the needs and the preference of the patients and their care patients. Sometimes you have patients who are not able to put the eye drops for themselves. We must make sure that the caregivers understand how to put on the medication for them. And it's important for patients with evidence of progressive diseases, and we have to be more aggressive, especially in young patients whose disease is very aggressive. We have to adopt an aggressive approach. For the older patients who are not so progressive or who are just retirees who may not expect such high expectation from the visual field, we just go on with the regular control as expected. So patients sometimes don't understand that they need to do frequent assessment and follow up, and they must put forward to their doctor if they encounter any problems in their eyes or they encounter problem with the medication, because if you don't tell the doctor doesn't know as well. So most of the time when I see the patient, the first thing I ask them is there any problem? How are you? So because sometimes you don't ask them, they think that you know. So doctors don't have telepathy, so it would be good for patients to bring forward to their doctors, develop a very good relationship with the doctors in order to have a very good control. So this is my message to everybody. The only way to predict there's a cloud, the only way to predict if there's a cloud on your horizon due to glaucoma is to get tested. If you don't test it, you don't know. No matter what the diagnosis, the focus is for clear vision in the years ahead. That is my presentation. I'll be willing to take any questions. Thank you for your attention.
Thank you so much, Dr. Linda Teo. I think we will meet Mr. Robert again, and we have a few more questions to ask him about his experience with this disorder. So, Mr. Robert, how does having glaucoma, how do you feel about this disorder, and how does it affect your life?
Okay, apart from having to be diligent with the medication. As of now, with 41% loss of each eye, it doesn't affect my lifestyle or how I go about doing things. Initially, when I lost some part of the top portion of my visual field, I needed to get used to doing things differently because sometimes I knock my head as I get into the car or certain low barriers, I knock my head because that part of the visual field is gone. But very soon I learned to adapt to it, and as of now, it hardly affects my lifestyle at all.
Okay, that's good to hear. How do you feel about family support? Do you feel that you are more dependent on your family compared to your peers due to having glaucoma?
No, I don't feel that I need any more assistance from my family than before, even if I don't have this disease. Even my dad, whose visual field is less than mine, he still go around life as usual. I mean, I'm not inhibited physically anyway because of this disease now.
So that's really good to hear. Thank you so much, Mr. Robert.
You're welcome.
Okay, Dr. Linda, I think I have a few questions that I would like to ask you. Okay, seeing that Mr. Robert has a family history of glaucoma, what age would you suggest patients who have a family history, either in their first degree relative, their parents, their siblings having glaucoma, at what age should they start screening for glaucoma?
If there is a family history of glaucoma, it puts the person in the family 10 times higher risk of getting glaucoma. So it doesn't matter at what age, especially if the patient is understand maybe is in the 20s or late teens. If there's a very strong family history, then it's better to screen anytime, because you see what happens. As long as there's a very strong family history, it can happen at any age. And especially if there are people in the family who have lost vision, that means to say that probably the glaucoma is a very aggressive form. There are some patients who may have glaucoma for years and there's no progression in the visual field. And there are some patients who have also about having glaucoma, but it progresses very fast. So different patients have different levels of progression. So especially if you have a strong family history of glaucoma, it is imperative that you should go and screen for glaucoma as soon as possible. And if let's say it's negative, maybe you say before the age of 40 and you've got a family history of glaucoma and your first checkup shows that you have nothing very suggestive of glaucoma, maybe you can again check up again every 2 years up before the age of 50. After the age of 50, then maybe you might want to do it once every year, because you know that glaucoma is actually more or less a disease of the older age group. But because of the strong family history, that puts the patient in the 10 times extra category, so you better check it at least once a year after the age of 50.
All right, that's great. And what about a patient who says, I have no family history of glaucoma at all? Do they need to screen at all?
Yes, they do. If they have no family history of glaucoma, if they have they are very high myopic, that means they are very short-sighted. If they have had LASIK done before, because LASIK patients are usually very short-sighted people. And I've seen many cases whereby glaucoma is missed after LASIK. That's because once they have done the LASIK, the cornea thickness becomes less. It's what you call the thin out the cornea. And when the cornea is thin out, whenever you go to check up, you won't realize that the pressure is actually lower than what it actually should be. That means you get a falsely low pressure. And then sometimes our patients, they don't tend to volunteer information. They may do LASIK with Dr. A, and then they go and see Dr. B and C and D, and they don't mention that they have had LASIK done before. So they might just want to say, oh, I want to check for glaucoma, and then the doctor says, hey, your pressure is all right. But the doctor doesn't know that the patient has had LASIK, and they subsequently miss the idea that the patient actually has glaucoma because of the normal looking pressure. So with LASIK, the pressure becomes lower than normal. So in other words, the central cornea thickness is important because it can make you miss the diagnosis of glaucoma. And patients who have uncontrolled diabetes as well, they should have eyes checked, because sometimes the uncontrolled diabetes leads to proliferative diabetic retinopathy and subsequently leads to neovascularization and subsequently leads to neovascular glaucoma. So there are a lot of things that can give rise to secondary glaucoma.
Thank you so much, Dr. Linda, for that very insightful talk on glaucoma. And also Mr. Robert Kung for sharing his knowledge and priceless experience with this disorder. Thank you.
You're welcome.
You're welcome. Thank you.